In today's discussion, we're focusing on a very important area of lipidology, namely hypertriglyceridemia. Before we get into the details, always keep in mind its two major clinical concerns. First, the prevention of acute pancreatitis, especially when triglyceride levels are very high. Second, the reduction of atherosclerotic cardiovascular disease risk, or ASCVD. And in that context, LDL cholesterol remains the primary treatment target. Now, let's talk causes. We broadly divide them into primary or genetic causes and secondary causes. Primary hypertriglyceridemia is usually polygenic, meaning multiple genetic variations contribute along with environmental factors. Examples include familial hypertriglyceridemia, familial combined hyperlipidemia, and dyslipidemia. Of these, familial combined hyperlipidemia is the most common inherited lipid disorder and may present with elevated triglycerides, elevated LDL cholesterol, or both. However, in routine practice, secondary causes are far more common and must always be actively excluded. These secondary causes are crucial because identifying and correcting them can significantly improve triglyceride levels. Metabolic causes include type 2 diabetes mellitus, where poor glycemic control increases triglyceride production through increased free fatty acid availability and increased hepatic VLDL synthesis. Obesity, especially visceral obesity, is strongly associated with insulin resistance and elevated triglyceride levels. Metabolic syndrome and insulin resistance similarly increase hepatic triglyceride production and reduce triglyceride clearance. Endocrine causes are also important. In hypothyroidism, reduced thyroid hormone activity decreases lipid metabolism and can contribute to elevated triglycerides. During pregnancy, triglyceride levels naturally rise, especially in the third trimester. But marked hypertriglyceridemia during pregnancy requires careful monitoring because of the risk of acute pancreatitis. Renal causes such as nephrotic syndrome and chronic kidney disease alter lipid metabolism and increase triglyceride levels. And finally, other associated conditions include chronic liver disease, systemic lupus erythematosus, and multiple myeloma. Now, let's discuss the dietary causes of hypertriglyceridemia. Diet plays a major role. One of the key contributors is excess caloric intake. Extra calories are converted into triglycerides and stored as fat. Another major contributor is refined carbohydrates. Examples include white bread, sugary foods, and processed carbs. Special attention should be given to fructose and sucrose-containing beverages. Sugar-sweetened drinks can significantly increase hepatic triglyceride production. High glycemic index foods also cause rapid glucose spikes and stimulate triglyceride synthesis. Excess alcohol intake is also a very important cause. The general cut point is more than 2 drinks per day for males, or more than 1 drink per day for females. However, when triglycerides are above 500 milligrams per deciliter, dietary fat also becomes an important contributor, and restricting fat intake really matters. And now, moving on to medications that can increase triglycerides. Several commonly prescribed medications are known to raise triglyceride levels. These include thiazide diuretics, glucocorticoids, beta blockers, oral estrogen therapy, tamoxifen, and retinoids such as isotretinoin and esotretinoin. Also, HIV antiretroviral therapy and atypical antipsychotics, particularly olanzapine and clozapine. Therefore, a careful medication history is an essential part of the evaluation in every patient with hypertriglyceridemia. Now let's move on to the principles of managing hypertriglyceridemia. The management of hypertriglyceridemia has two main goals. First, to prevent acute pancreatitis. The risk of pancreatitis rises progressively above 500 milligrams per deciliter and becomes particularly significant when levels exceed 1,000 milligrams per deciliter. The second goal is to reduce atherosclerotic cardiovascular disease risk. Although elevated triglycerides are associated with cardiovascular disease, the evidence supporting triglyceride lowering alone for ASCVD prevention remains limited. Therefore, LDL cholesterol continues to be the primary treatment target for cardiovascular risk reduction. Now, let's discuss the stepwise management approach. Step 1 is to identify and correct secondary causes. Every patient with hypertriglyceridemia should be closely evaluated for poor diabetes control, thyroid dysfunction, kidney disease, alcohol intake, contributing dietary factors, and also medications. Correcting these underlying factors forms the foundation of treatment. Step 2 involves lifestyle therapy, which is really the cornerstone of management. Weight loss of approximately 5 to 10% can significantly lower triglyceride levels. Physical activity is also key, with a recommendation for at least 150 minutes per week of moderate intensity aerobic exercise, or 75 minutes per week of vigorous activity. Step 3 is dietary management. Dietary recommendations should be tailored to the severity of hypertriglyceridemia. In general, patients should reduce refined carbohydrates, sugar-sweetened beverages, high fructose foods, excess calories, and saturated fats. Instead, encourage a diet rich in vegetables, whole grains, lean protein, and fish rich in omega-3 fatty acids. Now, regarding alcohol, for moderate hypertriglyceridemia, intake should be limited. But for patients with triglycerides at or above 500 milligram per deciliter, complete avoidance of alcohol is recommended. Now let's move on to step 5, drug therapy. Drug therapy for hypertriglyceridemia primarily includes statins, fibrates, and icosapent ethyl. But before starting triglyceride-lowering medications, it's essential to optimize LDL cholesterol management. Remember, statins remain the foundation of ASCVD prevention. In addition to lowering LDL, statins can reduce triglycerides by about 5 to 15% overall. And with high-intensity statins, the reduction may approach 25 to 30%, especially in patients with elevated baseline triglycerides. Now let's discuss management according to triglyceride levels. First, moderate hypertriglyceridemia, triglycerides between 150 and 499 milligrams per deciliter. The main treatment goal here is ASCVD risk reduction, as the risk of pancreatitis is minimal. Management includes lifestyle modification and statin therapy based on LDL levels and overall cardiovascular risk. If LDL targets are achieved and lifestyle interventions have been optimized for about 12 weeks, reassess risk. In patients with high ASCVD risk, consider adding icosapent ethyl. For those with low ASCVD risk, continue lifestyle measures and statin therapy. At this stage, there's generally no role for fibrates because pancreatitis risk is low. For moderate to severe hypertriglyceridemia, management has two primary goals. First, prevent pancreatitis. Second, reduce cardiovascular risk. This involves statin therapy when indicated, alongside intensive lifestyle changes, very low sugar intake, restriction of dietary fat to about 20 to 25% of daily calories, and complete avoidance of alcohol. For patients with high atherosclerotic cardiovascular disease risk, add icosapent ethyl. If triglycerides remain elevated, consider adding a fibrate. In patients without high ASCVD risk, fibrates are appropriate and prescription omega-3 fatty acids may be added if needed. Now, for severe hypertriglyceridemia, triglycerides of 1,000 milligrams per deciliter or higher urgent intervention is required, mainly to prevent acute pancreatitis. These patients need a very low-fat diet with about 10 to 15% of calories from fat. In recurrent pancreatitis, even less than 5%. At these levels, even healthy fats like nuts, vegetable oils, and avocados can trigger pancreatitis. Drug therapy options include fibrates as first-line triglyceride-lowering agents, icosapent ethyl, prescription omega-3 therapy, and in select cases such as familial chylomicronemia syndrome, olezarsen. In an acute pancreatitis with severe hypertriglyceridemia, intravenous insulin infusion may be used. Now let's talk about cardiovascular risk reduction in patients with hypertriglyceridemia. For patients with persistent triglycerides at or above 150 milligrams per deciliter, despite lifestyle changes and optimal LDL management, and who have increased cardiovascular risk, icosapent ethyl is preferred for ASCVD risk reduction. For those without high ASCVD risk, but triglycerides 500 milligrams per deciliter or higher after lifestyle modification and LDL optimization, reasonable options include prescription omega or fibrate therapy, with fenofibrate generally preferred. Fenofibrate is better tolerated, once daily dosing, fewer significant drug interactions, and safer with statins. Gemfibrozil should generally not be combined with statins because of increased risk of myopathy and rhabdomyolysis. If you liked the video, don't forget to subscribe and share it with others.